Okay, so finally got myself live. All right, guys, had a little glitches there, but we got things going, and I'm gonna go ahead and get us live on Instagram. So for those of you who are watching the replay, thank you for watching. Go ahead and give me a shout out in the comment section. You can comment replay. You can comment, hey, Cosi. You can put your question in. I do go back after each show has ended and I check the comments just to see if there's any stray questions. So we're going to give you guys a minute or two to jump on board. Let me get my chat section ready. Get ready to answer everybody's questions. We got a lot of questions that came in tonight, and I'm always happy when that happens because that's the whole point of the show. All right, so I'll have a lot of fun tonight just kind of telling you guys a little bit about my experience with Poland. I just got back from Poland and speaking at an amazing conference there. So truly just a wonderful experience. All right, guys, I see some of you jumping on board. As you come on board, hey there, Sydney. We got Johnny V coming in also on the Instagram channel. Thank you guys for watching. As you come on board, guys, you know the routine. Let me know who you are, where you're from, and what is in your mug. Yes, I broke down. I decided to start drinking the proverbial Kool-Aid, and I have gotten one of these crazy huge Stanley mugs, but you know I had to make it all girly and feminine. All right. We got Mark on board. Good to see you, Mark. We got Tom. Oh, hey, Tom. Thanks for coming. Scott, I am so excited to hear about you using your arm bike right now. So thank you for sending me that update. And we got Earl coming in from California, watching me on the YouTube channel. So guys, it'll be, I am broadcasting to YouTube, Facebook, and Instagram. So let me go ahead and see. We got Kim coming in from Indiana with her Coke Zero. All right. And over on the Instagram channel, we got a couple people over there as well. Awesome. All right. Whew. Okay. Everybody got their costumes ready for tomorrow? I know my kids are kind of excited about that. I'm going as the tired mother of four. How do you like my mask? Is it good? Is it scary enough right there? Okay, guys, I'm going to give you another half a minute to jump on board. Thank you, Mark. I appreciate that. Still a little jet lagged from my trip, so it's a little crazy this evening. We got Martin here from Loveland, Colorado, and he says, I've got a fourth of my cup with coffee. Only a fourth? You need a little more than that, Martin. But no, we are coffee fanatics here on the Cosi Talk Show, so you are in good company, Martin. All right, guys, we're going to go ahead and get started. For those of you joining me for the first time, welcome. My name is Cosi Belloso. I'm a physical therapist here in Tampa, Florida. I've been a PT now for a little over 23. I'm losing count. That's how long it's been. And my passion is working with the amputee and limb loss community. Hey, Ted, glad you could join in. There's my Alex. There's my Carolina boy. Good to see you, man. Good to see you. We got Emily here. Emily, you know how to scrape those questions in just at the last minute, Sheik. I've got your question here. So, guys, I am back from my trip to Poland. Specifically, I went to Krakow, as they say over there. I was invited by this, let me see if I can pronounce this correctly, Snowbieju clinic that they have there that is for amputees. It's an amazing, and they call it the Forum Amputacji. I don't know, hopefully I pronounced that correctly. But truly an amazing symposium. There were several prosthetists, physical therapists, surgeons there from not only Poland, but from the Ukraine, from France, and I think I heard German being spoken there as well. So it was my first time giving an international talk. And just truly an amazing experience. And I was very fortunate to be able to take my oldest daughter. She just turned 18, so we just kind of made it a 18th birthday celebration as well. Hey there, Tatiana. Thank you hey, Andre. Thank you for being here. I appreciate it. So it was really interesting. And for me, it was just also fascinating just to kind of compare stories. You know, Poland obviously has a very different healthcare system model than what we do here in the States. But it sounds like a lot of the obstacles that we face here in the United States, they are also facing in Poland with regards to amputee care. So it's always interesting to hear how other folks are doing as far as clinicians and clinical care and the research that they are doing and how they're managing the obstacles and how they treat their patients. So it was really, really a wonderful, wonderful experience. And I can't say enough nice things about the country as a whole. Beautiful country, Truly, if you've never been to Krakow, it should be on your bucket list. Between the natural wonders that they have there, the rich history, ancient and modern history, you could easily spend several days seeing everything there. And the people are just absolutely wonderful. Absolutely wonderful. Good food. Real good food. Oh, awesome food. All right, we got Michelle in from Michigan. We got Glenn. It truly was an amazing trip, Glenn. Hey there, Christy. We got Pastor Dave on board. We got John. John, I have your question ready to go. We got Harsh on board. All right, guys, so let's get started with the first question. And for those of you watching on my Instagram channel, don't be shy. Y'all are my quiet ones over there. All right, here we go. So Mina sent this question in. She is from Australia. She says, I've been following you for years. I became a bilateral below the knee amputee through severe illness at the end of 2012. I'm currently 64. I took my prosthesis home in May of 2013, and I haven't been back in a wheelchair since. I wear my prosthesis from early morning till late at night, and I go to exercise physiology twice a week. I'm loving this Mina gal. I'm active with cooking and baking, which keeps me on my feet, and I'm trying to concentrate on my lower body and residual limbs. I have very short stumps, so no calf muscle at all. I have tried and abandoned the ability to go from sit to stand without the use of my arms. I have severe osteoarthritis in one shoulder. Any exercises that you would recommend to help me achieve my goals? Okay, so first of all, my hat off to Mina. I mean, honestly, like the level of activity that she is doing, and it's very obvious that she's been working very hard to maintain her mobility and her fitness since bilateral below the knee amputation. So bravo to you, Mina. I hope some of you listening out there are kind of encouraged by how hard she works. When it comes to sit to stand, I mean, yeah, that's a hard, challenging activity. People really kind of take it for granted, being able to do the activity of just standing up on your own without having to use arms. And I picked up, interestingly enough, I picked up a lot of hacks for doing this when I was working in home health. And I worked home health for several years. And, the reason being is when you go into someone's home, they're not equipped with hospital equipment, right? So they're not going to have high chairs and wheelchairs and, different pieces of equipment to help people with their mobility, right? So a lot of times I would find my patients sitting in their living room sofa and they would be stuck because the sofa was down so low. So I spent a lot of time working with my patients, patients with one anatomical leg, two anatomical legs, no anatomical legs, and helping them learn how to stand up again. So one of my favorite hacks for everybody is to practice, squat is like sit to stand, right? So the ability to squat is how you do a sit to stand transfer. Okay. So I would go around my patient's home and I would hunt down all of the pillows that were like throw pillows like this. And I would literally, hang on, Bob, move out of the way, buddy, stack them. Okay. So I would find a chair and I would stack several pillows, one on top of the other, right? And my patients were always looking at me going, what is she doing? What is she doing? Okay. And then basically what would happen is I would have them sit on the pillows. And obviously they would be sitting a whole lot higher, right? So it was a lot easier for them to get into standing from that position. And guys, there were some people that were very, very weak, and I had them on like 5 or 6 pillows. Like they were practically in standing already. Okay. So this was basically just to get them strong enough to do like mini squats. Okay. So I would stack them up high and then I would just have them stand up from there and have them slowly sit down. So the devil's in the details. You do your strengthening when you contract a muscle, but also as the muscle is slowly relaxing and controlling that as well. That's called an eccentric contraction. Okay, it's a lengthening contraction. So I would find that when I would have my patients do sit to stand, then I'd have them go from stand back to sitting very, very slowly. Okay. And this would really help them build their strength up. So I would have them do several repetitions doing that. And then, if their goal was to try to do it without their arms, we would, get to the point where they could do it without their arms. And then as they got stronger, we would pull out one pillow and it would just slowly lower the height down. So I found this to be a really effective, sorry, Bob, a really effective way of teaching them strength training to get them from sit to stand and being able to do that activity and doing it in a safe way. Stephen says, I was swallowed by a sofa. Dude, I kid you not. So many times I would walk into my patient's home and the patient's wife or husband was looking at me going, help, I can't get my loved one up out of this sofa or this chair or, one of those things, right? And then this also applies in another functional way where toilets, right? There's a lot of toilets out there that are not necessarily very high. So, this is kind of one of those skills, those life skills that you're like, yeah, we need to know how to sit to stand without using our arms if possible. Okay. Another thing, if you are a bilateral below the knee, meaning you have your anatomical knees, okay, using momentum, especially in some of my folks who have problems with their shoulders, like Nina does, in the sense that she has arthritis in her shoulder. Okay. So I would help patients and just kind of figure out a way. Sometimes it would mean positioning both feet a little bit further tucked underneath them. Sometimes it would mean having 1 foot forward, 1 foot back, and then teaching the person how to rock. So using momentum to your advantage. And instead of putting hands on the armchair, maybe just putting the hands on the seat. Okay. And again, I know you guys can't really see what I'm doing here. So I'm just going to try to, you just basically put your hands on the seat and then rocking forward and just basically 1, 2, 3, and really kind of just use momentum to help propel you up. Sometimes people would be like, but I feel like that's cheating. And I'm like, if it's safe, okay, if you're doing it in a safe way, like you're not launching yourself into the next room, and it's helping preserve your joints that perhaps have arthritis, then yeah, do it. Do the technique, okay? So I find that sometimes with my bilateral below the knee amputees, this is also a helpful strategy as well. And again, it does take practice. If this is something that you're practicing on your own or with a loved one, I would usually have a person put the walker in front of them. And again, just practice that rocking technique until they could get themselves kind of up and steady and practicing that. So those are probably my 2 favorite hacks for getting that sit to stand. My bracelet like keeps falling off on me, for getting up into standing. And then again, guys, a lot of people beat themselves up because they're like, I can't get up into standing without using my arms. And that's okay. That's really okay. And guys, it's not, there's times where, I'm working with a patient and I see they do have certain physical limitations and they are simply not going to be able to stand up without having some use of their arms. And that's okay. Okay. The point is you want to have the maximum amount of mobility and independence as safely as possible. And that's the ultimate end of the goal. If you can get up off that sofa by yourself using your arms, call it a victory. Let's call it a victory. Okay. Oh, Mina, thank you. Okay, I'm glad you were able to be here this evening. I know it's a much different time for you over in Australia. So hopefully that those tips and tricks will help. And it's just kind of giving me idea of like, this is a great video for me to make for Instagram where I can hopefully demonstrate it a little bit better than the confines of this screen right here. So I have another conference I'm speaking at this weekend, but I promise you next week I will make a video and I will post it on Facebook and Instagram. So make sure you hold me accountable for that, to do that. Let's see. A few people came in, so let me just give a shout out here. All right, we said hello to Michelle. Hey there, Kathy. We got Stephen Schreidel on board, and we got Pam on board. Kimberly here in Utah, chemotherapy day for her. Oh, okay. All right, Kimberly. Well, I'm glad you're here with us, and I hope you feel better. I really do. We got Greg coming in from Arkansas. We got Jerry Ann here from Arizona, and she's got white chocolate coffee. Man, y'all bring some seriously good drinks. We got John Cummings on board, and I love it. Steve was like, I was swallowed by a sofa. Pam says, I learned to put thick blankets between the cushions, which would help elevate the sofa. And as I got stronger, I pulled out the blankets and the comforters. That's a wonderful strategy right there, Pam. That's very, very good. And yeah, when you're using the pillows, I used to have to be very careful with my patients and teaching them because, obviously, if you sit down on a whole stack of pillows and you don't do it properly, you can slide off. So usually I would either teach the family member like, okay, let's hold the pillows in place while they're standing up and practicing sit to stand, or pick pillows that are nice and flat so they stack easily. to help out with that. We also did that in the hospital as well. I'm trying to think. I think it was one of my mentors from really early back in the day that taught me that trick. And I was just like, it really works. Hey there, Rhonda. All right. And then Ashley says, my second day home after my amputation, I sat on my sofa and I got stuck. Thankfully, my sister and brother-in-law stopped by to visit and helped me. Guys, it happens a lot more often than you would think. I mean, it right? And again, it's just one of those things where things that you take for granted. And it just reminds me of this conversation I had with Dr. Shu. He's the amazing surgeon who's been on my show more than one occasion. And he was recently on the show talking about the rates of infection with osseointegration, right? But in our conversation about osseointegration, he said, sometimes I just took it for granted with my patients when I would ask them why they wanted osseointegration. And the patients would turn and tell him so that we could just sit on the toilet without scratching up the toilet seat with our sockets. Just something very basic, but, something that really kind of impacts quality of life, right? So things like being able to sit on your toilet seat without your leg coming off, or, being able to stand up from the sofa. Things like that you just take for granted. Hey there, Victor. Donnie says, am I doing anything in Florida with regards to conferences? Not at the moment. Well, actually, I'm giving a speech, but it's not really like a conference. It's more of just like a small lecture to a group of physical therapists at an Encompass hospital here in Florida. But no, this weekend I'm attending, and I'll be helping at a presentation for osseointegration at in Charlotte, North Carolina. So I'm really excited about that talk and getting to see a lot of my esteemed colleagues. I'm really excited about hanging out with them. And then for the rest of the year, I get to just breathe just a little bit. I've done a lot of traveling this year. I was kind of looking at my airplane ticket situation. I'm like, wow, I've been to a lot of amazing, wonderful places this year. Went to Guatemala with my children to go help out the amputee clinic there. Got to go to Empower Fest hang out with the Hanger folks at Empower Fest. Got to do the Amputee Coalition with College Park, Poland just now, and I'm missing someplace else. Oh, Nashville. I went to Chattanooga to go speak at Ronnie Dixon's clinic in Prosthetic Orthotics of Tennessee and Associates of Tennessee, and that was an amazing experience. It's been a busy year. Hey there, Eric. Oh, man, good to speaking of POA of Tennessee. There's my boy Eric right there. Larry asks, I continue to struggle with balance and walk-in. Can I use four-wheel? And it sounds like you got cut off there, Larry. Can you rewrite your question, please? Hey there, Andrea. Good to see you. Eric says, I had a class of physical therapists come through our clinic and was able to talk to them. Go, Eric. Hang on. No, Mark, not the Encompass down there. It'll be the Encompass in Largo, which is near St. Petersburg. David says, most couches and chairs I found are not always amputee friendly, and I've gotten really choosy over what I sit on. Let me tell you, Pastor Davis, they're not amputee friendly, and they're not like older folks friendly either, because like even my knees are kind of complaining a little bit when I try to stand from some of these sofas nowadays. Howdy, Ben Gregory. Oh, good to see you, man. All right, let's get this next question. We've got John here. Oh, this is a good one. So John says, I'm an AK with a C leg, C4, which is a great leg. Who still has balance issues. I was watching your 1, 2, 3 step cockroach video, and it got me wondering if I'm using my prosthetic correctly. I use a walker, and my question is bending the prosthetic knee slightly and taking half a step and then a full step with the good leg the correct way to walk? I was taught to take a smaller step with the prosthetic leg, but was told not to bend the knee slightly. Is the procedure used until you gain enough confidence and balance? And the reason I ask is I've seen a lot of homemade videos of above the knee amputees walking, and they're not taking the bend knee half step with the prosthetic leg. So for those of you who are wondering, like, what am I talking about with the 1, 2, 3 step cockroach? So it's kind of a walking exercise strategy that I use with my amputees, and it's in my exercise, the Strong Body Exercise program. Over the years, I've kind of been modifying how I teach walking. And if you talk to physical therapists, what we did at the beginning of our careers is not what we're doing, 2 decades afterwards. And I certainly have changed my strategy and my approach, and it continues to evolve, over the years, as it should. So for those of you who haven't seen my videos on the gait cycle, on the human gait cycle, how we walk and how the gait cycle is broken down, I would strongly encourage you to go check it out on my YouTube channel, which, by the way, you can just find it under Cosi Talks. And the reason why I'm like shamelessly plugging this is because when you understand how the gait cycle works, it's going to kind of help you understand, as an amputee, what are the parts that you really need to focus on and to work on so that you can become proficient with your prosthetic leg. Okay. And I find that when I explain the different steps of the gait cycle to my patients, they have a better understanding of why we're doing the things that we do. Okay. So it brings me to my long-winded point. And I actually mentioned this a lot in my lecture in Poland. When I am teaching the gait cycle to an amputee, I'm teaching the human gait cycle. Okay. I'm not teaching prosthetic gait, if that makes sense. Okay. So when I teach human gait cycle mechanics, I am teaching it to them as I would teach someone who had a stroke, or someone who had a traumatic brain injury, or someone who broke their leg and is recuperating from that. Okay. And the reason is because I want them to have as normal mechanics as possible. I want them to walk as normally as possible, because that will make them efficient with their gait. It means they will spend less energy while they're walking. Okay. So when it comes to, especially my above the knee amputees, teaching them how to take that first step. Okay. I've kind of changed my strategies a little bit. It used to be that I would teach the person how to put their heel down first and then put the weight into the heel and move forward, right? But that's not how I teach it anymore. I start teaching it from the point where they have their entire weight on the prosthetic foot. Okay, so I kind of teach it at the halfway point. And I know it's kind of hard to like visualize what I'm saying. And I'm realizing now that I probably need to make another video on that one as well. Okay, but in John's case, thankfully, hopefully, John, you got my message. He lives what I consider to be close to an expert physical therapist who works with amputees. So I'm really hoping, John, because just from hearing what you're explaining with your question, you need help learning how to bend the prosthetic knee. Okay. And that's a big one among our above the knee amputees, whether you're using a mechanical knee, whether you have a microprocessor knee. Okay. Learning how to load that knee and trust it when your foot hits the ground, and then learning how to bend that knee, specifically how to unlock that knee to get it to swing through. Okay. Those are just key points during the gait cycle. Okay. And working with a physical therapist who understands prosthetic devices and understands human gait and how to teach it, it's really going to give you a nice advantage there. Okay. Now, with regards to being able to bend that knee properly, and it's the Ottobock C leg. So with the Ottobock C leg, if I'm not mistaken, it is, I can't remember if it's low dependent or position dependent. Basically, your leg has to be positioned far back enough to allow that knee to bend properly and swing through properly. Okay, so I know I'm kind of getting into the weeds right now with all of this, but my point to you is, John, I have sent you the information to a therapist who is relatively close to you, and I'm really, really hoping that you'll be able to connect with her, because I know she will be able to help you with deciphering that prosthetic knee and getting you on your way with human gait pattern. Hey there. Speaking of which, there's my girl, Michelle, physical therapist extraordinaire. Hey guys, by the way, I usually don't participate in all like the themed months, and I think, but October is kind of my month. It's physical therapy month. I believe it's Hispanic Heritage, or is it Hispanic Heritage Month? I don't even know. And Breast Cancer Awareness Month. So we've got a whole lot of stuff going on in October. But in the meantime, go hug your physical therapist. And there's a beautiful example of one right there, Michelle with Align Rehab sitting in here today in the audience today. Okay. So Larry says, a cane in my hand and I cannot hardly take a step without losing my balance. I do PT twice weekly and have had a ton of setbacks with wounds in the past 4 years. I'm sorry to hear that, Larry. Again, if you are, so there's a lot of reasons that you could be losing your balance when you let go of that cane. Certainly if you have a lot of setbacks from wounds, and that could be causing pressures in your socket, coming from pressure in your socket. If there's any discomfort with your socket, then that is certainly going to contribute to balance issues. If you're not comfortable in your socket, it's going to be very, very difficult to walk. So if that's part of the problem, Larry, then I would definitely continue to be working with your prosthetist to make sure that that socket is fitting properly. Okay, next thing is if your physical therapist is experienced with working with amputees, then I want you to ask them, why is it that I'm losing my balance? Is it because I have a specific weakness? Is it because I have balance issues that need to be worked on and practiced more? Is it because of my sense of proprioception? So meaning my brain does not know where my foot is in space, which happens to every single amputee, and having to do exercises that are specific to helping with that. So Larry, communication is really, really important, and your physical therapist should be explaining to you the plan. It's not just throwing spaghetti at the wall and seeing what sticks. Ask your physical therapist, why do I keep losing my balance when I let go of the cane? What is the impairment? What is the obstacle here? And how are we addressing it with treatment? Okay, if your physical therapist can't answer those questions and explain this to you, then it might be time to look for a new physical therapist. Okay, and again, I'm not trying to throw shade on anybody in my profession, but some physical therapists simply don't have the experience of working with amputees. Okay, so ask them these questions. Ask them these questions and see what they have to say. Hey there, Pam from Indiana. Let's see. Donnie says, agreed. Relearning to walk again means starting at ground zero, and every time I get a new leg, I go to PT and learn again. Bravo, Donnie. And that's something that I highly, highly encourage. Again, whether you're getting a new prosthetic foot, certainly a new prosthetic knee, sometimes even a new socket, okay? All of these changes will affect how you walk, okay? I mean, just think about it this way. When you have a tiny, tiny pebble in your shoe, with your sound foot, how does that change how you walk, right? Every time you step on that pebble, you're doing something different and you walk differently, right? So the same thing when you have a new prosthetic foot, it's going to change a little bit how you're walking. So for my own patients, I always tell them, guys, even if I've discharged you from my care, please keep in touch with me. And if you have a new foot, new socket, send me a video of how you're walking and I'll let you know if there's something we need to correct. Ben Gregory says, I met a new bilateral below the knee amputee today. Are there wheelchair exercise videos on your YouTube channel? Wink, wink. I love you, Ben Gregory. You're awesome. So on my YouTube channel, no. On my Strong Body program, yes. So here goes the shameless plug number 3 for tonight, because you guys know I love my shameless plugs. Hang on. So if you got strongbody.cositalks, I hope I wrote that address correctly. Hopefully that's right. As you can tell, I'm still a little bit jet lagged and I need a little more sleep. So guys, I do have a Strong Body program. It's 150 video exercises for above the knee and below the knee amputees. It covers head to toe strengthening. It also has the ability to have 2 books full of exercises for amputees for above the knee and below the knee. These exercises are shown with and without the prosthesis. So to answer your question, Ben Gregory, somebody who wants to participate in doing exercises from their wheelchair can do so, because there's a lot of balance exercises here that are done from a seated position. Excuse me, Donnie, go ahead and click the link above, and that's the link to the Strong Body program. Glad to hear it. I like this program a lot. Currently it's being used in the Encompass hospital systems all across the United States, and I am so thrilled about that. So yes, there's a Strong Body program. Okay, guys, next question. We have a question from Andre. Hope you have your Moscow Mule today, Andre. And he says, I'm having my very first meeting with my prosthetists. And I guess that would be the plural there for prosthetist, because he was asking, what should I expect? So this is a question I get quite often, and I think it's very important. So in the first visit, honestly, a lot of it depends on where you are. Sometimes your first visit might be before your wound has completely healed, in which case it's usually an interview process. In some cases, your surgeon has, cleared you and said you are ready to go and be casted for your first prosthesis. So there's a lot of interviewing that should be going on in that first visit. And for me, it's just as much the prosthetist asking you questions and you asking the prosthetist your questions. Okay. The way you need to approach it is that you are interviewing your prosthetist. Okay. They are going to be providing you with a service, and you have the right to ask a lot of questions. Okay. And most prosthetists and physical therapists as well, we're pretty good eggs. We went into the field because we wanted to help people. So answering questions is part of what we do. So some of the questions that I recommend that people ask is, what is the prosthetist experience? Do they see a high volume of amputees, or do they typically see a high volume working with orthotics instead? What are their recommendations for the prosthetic feet? And will they allow you to trial more than one prosthetic foot? Okay. This one's kind of a big one for me, and you guys have heard me talk about this a lot. A lot of the manufacturers out there that make these prosthetic feet have wonderful trial programs, meaning that you can trial their foot at no cost and no commitment. Okay. And this is something that I really advocate for. You should at least trial 2 feet, at least 2 feet, and be able to make comparisons between the two. So to me, that's kind of one of those big questions that you should be asking. And, asking them the questions: what is the process? Are you going to be making my socket, or are you going to be taking measurements of my limb and then sending them off for the socket to be made elsewhere? Okay. There's pros and cons to both, but it's good to know what is the method that your prosthetist will be using. How long is it going to take for the prosthesis to be made? How often can you come back in for adjustments? And the correct answer to that is however many times it takes to get the fit right. Okay. One of the questions you would ask is, if you're having a problem with a prosthesis, how quickly can you get in to see the prosthetist if needed? Okay. Do they have, time in their schedule for little emergency visits if needed? Okay. How would you be getting in touch with your prosthetist? Do they have an on-call service? These things that you need to know about. So these are just some of the questions. And then the other thing is, it's funny, when I opened up my practice, my colleague, who was my business mentor and just kind of teaching me the ropes on the practical side of running a business, he said, marketing takes place in the waiting room. And I found that to be a really accurate statement, So, if you're a good clinician and you're good at what you do, your patients will be promoting you in the waiting room, because they'll be talking about you in the waiting room. So the flip side is true, though, too, in the sense that if you want to learn about your prosthetist or your physical therapist, chit chat with some of the people in the waiting room and ask them about their experiences of working with the prosthetist, and, find out the information, get that recon, and it might sound like it's a little sneaky, but, this is the prosthetist, this is the clinician that's going to be helping you, walk. So you want to make sure you got the right one. And same thing with the physical therapist, by the way. Yeah. All right. Hey, Helen, glad you could join in. All right. Let's see what else. Okay. Ooh, this is a good question. Martin asks, how do you know when you need to get a TMR procedure? Is there a point in time where it's too late to get it done? Okay. So TMR refers to targeted muscle reinnervation. We did quite a few shows back in 2022 with the company TMR Nerve. Okay. So what is targeted muscle reinnervation? When surgeons perform an amputation, Eric is like, do your research. Yes. When surgeons perform an amputation, they will, after they cut through the muscles and the soft tissues, they'll take the nerve, gently pull it, cut it, and then tuck it back into the soft tissues, right? That is kind of the traditional, it's kind of how they've been doing it for centuries, really hasn't changed a whole lot. So what happens is a ball of scar tissue starts to form around that nerve, and that ball of scar tissue is called a neuroma, okay? So the problem is if it's a sensory nerve, then that can cause a lot of problems. Idle hands make devil's work. Okay. So if you think about that nerve ending just kind of flip-flopping around in that soft tissue, it's going to start to cause problems, and it causes problems in the form of pain, and oftentimes very severe, debilitating pain. In some cases, it can be pain that is just local to the limb, meaning you only feel it in your residual limb. But a lot of times, this neuroma will cause phantom pain. Okay, and phantom pain, that's one of those Pandora's boxes. But basically, phantom pain can be caused by many different things, but one of them is a neuroma. Okay, so how do you know if you have a neuroma? So if a patient comes into my clinic and they're talking about, man, this pain's really killing me, I'm automatically starting to think in my head, where is this pain coming from? So if the patient tells me, I feel the pain here, okay, and they point to a very specific place in their limb, then I do the Cosi two-thumb test, and I basically push my thumbs into that area. I know it sounds very cruel. If my patient jumps up in the air and tries to kick me, then I know that there is something there that's causing the pain, right? It's either a neuroma, or it's an abscess, or it's a bone spur, right? There is something physically there that's causing that nerve pain. And at which point I will send them back to the doctor, because I can't order x-rays. I can't order any of that fun stuff, right? And I send them back to the doctor to get it worked up, okay? Because if it's something that's there, that means that's something we can treat. Okay. I know it sounds weird to say it, but sometimes it's kind of a good sign when there's something there, because then we know we have a target. We can hopefully fix that, right? So, okay, patient goes to the doctor, they do an ultrasound, they find that there's a neuroma sitting there. Then what? Okay. There's a few different options. Traditionally, surgeons would go in and they would cut that neuroma out, and that's it. Well, what happens is, over the course of time, that nerve ending would form another ball of scar tissue and start the whole process again. So a gentleman by the name of Dr. Dumanian and another gentleman by the name of Dr. Kaiken back in 2002 discovered that if they took that nerve ending and they plug it back into the muscle, that nerve behaves itself because it's happy and it's doing its job. Now, that's kind of a really oversimplified explanation of that procedure, and my apologies to Dr. Dumanian for doing that, but that's in essence what they're doing. Instead of allowing that nerve ending to be flopping around in the soft tissue, they secure it into a very specific point in the muscle, okay? And that way the nerve starts to grow back in and it does its job, okay? And it's happy. So when it comes to phantom pain, it's actually a very, very effective means of maybe not taking it away completely, but certainly bringing the phantom pain down a lot. And they've had a lot of success with this procedure. Now, this only works if the phantom pain is coming from the neuroma. Okay, so remember what I said earlier, phantom pain can be caused by a whole lot of different things, But if it's being caused by the neuroma, okay, then they can do this procedure, okay? One of the things that they will do is when you go to the doctor and you say, hey, doc, I think I got a neuroma. I think we need to do targeted muscle reinnervation, okay? One of the things that the doctor will probably do is they may inject the neuroma, right? So they might inject it with like a lidocaine or something. And if your pain resolves, then they know, okay, yep, that's what causing that phantom pain. Yep, we want to do TMR, okay? Because at the end of the day, it is a procedure. You know, they have to go back in, open your limb back up and do a procedure. So they don't want to do that unless they know for sure that that is what's causing your pain. Make sense? Okay. Now, the next part of the question was, is there a point in time where it's too late to get it done? No. So when Dr. Dumanian was on the show, and again, guys, this was back in 2022. So again, go back to my YouTube channels and I've got lots of videos on TMR by the surgeon himself who pioneered this procedure. So really great information there. So what he said is, obviously the earlier you can get it done, the more effective it will be. And at least that's what the literature is starting to show. Okay. But he's had some people who were years out of their amputation and they had the TMR procedure done and they had success. And what I mean by success is not that their phantom pain went completely away, but that it was diminished. Okay. So here's my thoughts on TMR. If you are having your amputation done and you know you're having your amputation done, meaning it's a scheduled amputation, okay? You definitely want to talk to your surgeon about TMR, okay, and having it done at the time of amputation, okay? If you are going in for a revision for whatever reason, okay, talk to your surgeon about TMR, okay? And there's a whole list. If you go to TMR Nerve, let me write it down, tmrnerve.com, they have a whole list by state of surgeons who do TMR. And that's obviously who you want to go see, because not only because obviously they trained in the procedure, but they're also going to be able to tell you, yes, in fact, you have a neuroma, and yes, doing TMR is going to help you with this, okay? So if you're having a revision done, I would encourage you, find someone who is trained with TMR, because if you're already open on the table having a revision done, you might as well go ahead and see if there's any neuromas lurking around in there that could benefit from TMR, get it done, okay? And again, I have to reiterate, not all neuromas need to have TMR done. Does that make sense? Okay. But it is certainly worth having that conversation with your surgeon. Hey, good morning, Carl, coming in from Taiwan, man. That's awesome. Carl, what time is it over there for you in Taiwan? I'm just like, this whole time change thing is kind of cool. Donnie says, and keep in mind your medication can cause issues as well. I changed blood pressure medication 2 times to fine tune to not create swelling. If you're referring to how medication can affect your phantom pain, yeah, I've certainly heard of that for sure. I've heard, I think, pretty much every trigger under the sun when it comes to what will trigger someone's phantom pain. The number one, though, is stress, for sure, for sure. Martin says, can you email me the TMR link, that YouTube video, please? Yes. So if you guys go to youtube.com/Cosi Talks. Okay, so Martin, that's the link to my Cosi Talks channel on YouTube. And then if you go under the live video section, the name of the doctor is Dr. Dumanian. Okay, and in the titles on the videos, you'll see TMR Dr. Dumanian. And I've had actually several surgeons who perform TMR on my show. So just off the top of my head, Dr. Souza, Dr. Roubeau, she's a wonderful surgeon out of MD Anderson in Texas. So several surgeons on the show who talk about TMR. Dr. Tedeschi is another one. So go there and you'll find that information. tmrnerve.com is their website, so you can find a surgeon in your state who is trained. Carl says, we're exactly 12 hours apart until daylight savings time starts. So it is 9:30 in the morning. So yes, good morning to you, Carl. That's pretty cool. Okay, glad to have helped, Martin. All right, next question. Emily asks, as your limb shrinks, does the weight of the prosthesis change? Mine feels so heavy. So yes and no. Hang on, I just realized I haven't been checking in on my Instagram channel. Sorry, guys. All right, seeing you guys jumping there on board. Hey there, Gabriel. Mucho gusto. Bueno de verte a ti otra vez, Gabriel. Okay, so when it comes to the limb shrinking, okay, Gail says, I'm happy with my, I'm assuming you're meaning TMR, although I still have phantom pain sometimes depending on what I eat or drink. And again, guys, to me, phantom pain is a multifaceted thing. And it's one of those things where even the most brilliant minds, you know, working in amputee care, we still have not been able to unlock the secret behind phantom limb pain. We have a lot of theories behind it, right? And I think it's more than just one thing causing phantom pain. But certainly, if there's an angry neuroma sitting there in your limb, that's going to be a big contributor to it, okay? So again, it's worth having conversations. I'm not telling people, go, rush, get surgery done. No. But it's certainly worth having conversations with your surgeons about it. Tom is just like, change in weather can cause phantom pain. Okay, you know what? It's time for a Cosi poll. Time for a Cosi poll. I want you guys to write in the comments section, if you experience phantom pain, which I know many of you do, what is your trigger? Put that in the comments section. I'm always curious when I ask these questions. And again, one of the things that I even spoke to in the lecture in the conference in Poland this month, because the theme of the conference was pain in the amputee, right? The different kinds of pain that amputees experience and what are the treatment strategies we have. So one of the things I reiterated, and you guys have heard me say this on the show a lot, was, finding, first of all, what is the pain? Is it actually phantom pain or is it residual limb pain? Right? Two very different things. And then what is the trigger? Because if we can kind of find out what the trigger is for that phantom pain, it might give us a little clue on how to help alleviate it or maybe even avoid it. So Donnie says stress. Gail says sugar, alcohol. Victor says high blood sugar. Pam says magnesium. That's interesting. Eric says putting pressure on certain spots. So that's interesting, Eric, because when I hear someone tell me that they feel their phantom pain being triggered when they put pressure into it, especially when they're wearing their socket, it makes me think, what is in that residual limb that is causing it? So whether it's like a bony spur or a little neuroma or maybe even scar tissue. So things to think about. Rhonda says, yep, feels like foot there being pinched, but don't know the trigger. Ben Gregory says eating sweets, so sugar for him. Tom says overdoing it. Donnie says exhaustion. Jerry Ann says rain, cold weather. Martin says it's always pulsing. And when I get into bed, it gets really bad at times. Okay. So again, Martin, it would be, I think, very beneficial for you to go see a surgeon who's trained in TMR and just see why is it pulsing? What's going on there? And Pastor David says anxiety and sometimes doing a lot, overdoing it. Yeah. Okay, so going back to Emily's question where she was asking, as the limb shrinks, does the weight of the prosthesis change? Okay. So again, a lot of people, when they come to see me for the first few visits to learn to use their prosthesis, they'll say, this prosthetic leg is too heavy for me. There's just no way. And it's interesting for me when I look up their weight of their prosthesis and I show it to them, right? And compare to the weight of a human leg. Okay, the human leg far outweighs any prosthetic componentry, including even some of the heaviest componentry that we have out there. So obviously, because it's not connected to you, your brain is interpreting it as dead weight that you're lugging around. Okay, so the key to success of your leg feeling not heavy is good suspension and a good fitting socket. Okay, so you can have the heaviest knee on the market, which right now I think the heaviest knee on the market, if I'm not mistaken, it's the Oser Power Knee. I happen to like the knee. It's a great knee. And I've seen, one gal that I know of, a sweet lady named Whitney. She's a little petite little thing, right? She's maybe 5 feet tall, and she's wearing one of the heaviest knees on the market. And she's zipping up and down all over the place. Why? Because her socket fits beautifully, and she has a great prosthetist. And the suspension, how the leg is held onto her, is done very, very well. So Emily, if your limb starts shrinking, right, it means that the socket is going to be a little too big on you. And it means it's not going to fit as snugly. So it's going to make that prosthesis feel heavier. Okay. So this is where understanding how to manage your socks while you're wearing your prosthesis, understanding that as your limb starts to shrink, you need to immediately get on it and put on the extra socks that are needed to fill that gap in there. Okay, a lot of you use the Click Medical adjustable socket, which for me is like a godsend for people who have a lot of issues with their volume fluctuating, because they just have to twist the dial and it tightens up the socket or loosens it up as however is needed. Okay, so it's not your imagination, Emily. Your limb is going to feel heavier as your prosthesis is going to feel heavier as your limb shrinks because you're losing that suspension in your socket. Okay, and then you're saying, I can't always get my pin to lock in, so that probably doesn't help. Yeah. So, and again, if you're putting that pin lock in and you're like click, 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 lots of clicks, then that probably means that you're sinking too far into your socket and you need to add extra socks to it. So John says, my suction socket is comfortable and the weight of my prosthesis is not an issue for me. And again, when you're wearing some of the suction sockets, you get better contact because it's using that negative pressure to like suck you into that socket, and it kind of really fills the gap a lot nicer. So, not everyone is a candidate for a suction socket, but again, it's just reiterating the point that the more snug your socket fits, not tight, we don't want to strangle your poor little residual limb, but the more snug your socket is on your limb, the better suspension you're going to have. And yes, guys, this is something that it is very frustrating. And I have a lot of people who come in and they're just like, truly frustrated. And it's not, I keep telling you, it's not you. It's not you. It's part of the process. And this is, again, where you have to continuously go back to your prosthetist and continue that communication. As Scott says, I've been managing hyperthyroidism for a while now. One of the surprising issues encountered was chronic bad breath. Oh, wait, is this a spam? Oh, gosh. Seriously, dude? Really? Know your audience. All right. Anybody who is spamming will be blocked. Bye-bye. Okay. Emily says, I don't even get any clicks sometimes and it starts to fall off once. Yeah, if you're not getting any clicks and you're using your pin lock, that means you are not in that socket. So no bueno, no bueno. You've got to get that taken. Take a look at, have your prosthetist take a look at that, Emily. Okay. Holy smokes. Y'all send in a lot of questions, which I love it. So by the way, guys, we're going to do some housekeeping right now. So for those of you who are new to the show, here is my email address, okay? This show is meant for you. And when I mean you, I mean if you are a prosthetist, physical therapist, surgeon, clinician, amputee, caregiver, family member. This show is for you to answer your questions. So you can email me directly right there. You can also sign up for my texting. And guys, I need some new text subscribers. I love hearing from you guys. And texting is really honestly one of the easier ways for me to communicate with you. And I promise I don't spam. So if you text Cosi Talks, all one word in caps, to that number, you're part of my texting service, the Cool Kids texting service. So you'll receive a link whenever I go live. So some people find it easier to find me that way. And also you can text me your questions directly, which, by the way, guys, for those of you who have been texting me, thank you for including your name, because that does allow me to know who I'm talking to. And if you are signing up for the first time for my texting service, please just let me know, hi, it's so-and-so. You don't have to give me your whole personal information, but it's just nice to know what your first name is. Emily says, finally starting lymphedema therapy. Hallelujah. Oh my gosh, woman, you need that. And I'm so glad for you. Donnie says, my pin socket starts out good. I'm extremely active. And with the new socket, after about 30 minutes to an hour, it feels like it's on fire and I need to remove it and let it reset. Not sure why. So Donnie, I would say there might be something about the fit. So if you are very, very active, okay, if you're very active, within 30 minutes, your limb will start to shrink. And a lot of people are surprised by this. So again, what happens a lot is people start to shrink. They start to sink more into their socket and bottom out. And sometimes people don't realize that they're bottoming out until like their limb starts to hurt. So again, Donnie, this is something that I want you to take back. If you're working with a physical therapist, to them, or take it back to your prosthetist and ask them, why is my limb hurting after an hour? It should not. Here's the answer. It should not be hurting. Okay. So whether it's because you have to add more socks in or there's something going on in that socket, you need your prosthetist to lay eyes on it and help you troubleshoot what is going on. Greg says, hip disarticulation, if I'm reading that correctly, never had a shrinker or a sock. Is that correct? Yeah. Unfortunately with the hip disarticulation, there's not soft tissue there to really be able to put a shrinker on there. I've seen some people who do the wrapping with the ACE wrapping, but again, it's very hard to get a good suspension there. Footy clips. Oh, I like that name. Oh, well, thank you for that. I appreciate that. Let's see. Okay, for socks, 3 or 4. So, again, Donnie, you should not be experiencing pain in your socket, especially if in your previous socket you were able to wear it for long periods of time without any problem. Just because the design of your socket changed does not mean that you should be experiencing pain. So again, go back to your prosthetist and explain, this is what's going on. What's going on? help me fix it. Yeah? Okay, sorry. We got Fisioterapia Sabrina. Thank you for joining in. All right, guys. I think Lori's walking without any assistance. Woohoo! Go, Lori. Congrats. All right, guys. I think I have covered all the questions for this evening. Next week is my Veterans Day tribute. So it's a little bit early. It'll be next Wednesday. All of you who know me know that I have a very soft spot in my heart for the men and women who served our country in the military. So next week, I have a special guest, Dr. James Flint. He is a naval surgeon, oncology, specifically orthopedic oncology surgeon, and he works a lot with osseointegration. So that's been a real hot topic on our show the past couple of years, and we're seeing so much about it. So I'm always excited when I have a new guest on board to bring their perspective on osseointegration. So guys, tune in next Wednesday. If you are signed up for my e-blasts, which you can do that by going to my website. Hang on, last plug of the evening. CosiTalks.com. You can sign up for my e-blast there and you'll get first dibs on the giveaway information for next week's show. Let's see. Obrigado, Harsho, and happy Diwali to you. Festival of Lights. That's a beautiful festival. So guys, for those of you who are heading out on the streets tomorrow for All Hallows Eve, have fun, be safe, and I will see you guys next week, same bat time.